The specific carbohydrate diet, or SCD, is a diet used by many patients with IBD. It's a nutritionally balanced diet focused on removing grains, dairy, except for yogurts fermented over 24 hours, as well as sugars, except for honey. The diet focuses on natural, nutrient-rich foods, including vegetables, fruits, meat, and nuts. We know that the specific carbohydrate diet works. We're still learning a lot more about the specific carbohydrate diet, and a lot more research needs to be done.
The SCD can be a really good therapy for individuals, just as the soul therapy for certain people. But I also find that it's very good as adjunctive therapy, so medical therapy and specific carbohydrate therapy alongside each other to get people feeling better.
I lay out all the different treatment options for a patient, including dietary and medications. There are a lot of factors that play into making the SCD part of a treatment protocol for an individual. Those include making sure that the family has the ability and commitment and long-term desire to utilize dietary treatment. We use a number of criteria to help determine if the SCD is appropriate. This depends on the type of disease and the severity of the symptoms. While the SCD works for many, there are times when we would not recommend it as first-line therapy. In the case of Crohn's disease, an individual with stricturing disease, severe perianal disease, abscess, or fistula formation should not rely on the diet therapy alone as treatment. Nor should a patient use the SCD as the sole therapy if they are experiencing severe clinical symptoms such as abdominal pain and diarrhea. In these situations, using concomitant medication can assure disease activity is more quickly and completely controlled. Additionally, if an individual is having severe weight loss or stunted growth, especially if they're in their preteen or teen years, typically a time of rapid physiologic growth, SCD should not be used initially. Instead, a primary treatment of exclusive enteral nutrition, or EEN, is often used prior to the SCD. Once patients are doing well, transition to the SCD can occur. For more details on EEN, please refer to the information on the Nimble website. What about ulcerative colitis? As with Crohn's disease, in ulcerative colitis, if patients are having severe symptoms, the SCD is not a good option. If a patient needs hospitalization, or a blood transfusion, or has severe clinical symptoms, the SCD should not be considered a primary therapy. When trying to decide whether the SCD should be used, a patient needs to take into account the number of stools per day, the amount of blood in the stools, nighttime awakening for bowel movements, and abdominal pain. The more severe the symptoms, the more important it is to quickly get an individual into remission and therefore use medication. The SCD is a tool in our toolbox.
If the family is very insistent on trying dietary therapy, and I think that it is safe to do dietary therapy, I'll say, we can do this, but we have these sort of thresholds. We're going to come back at this point in time, we're going to assess these markers of inflammation, and if they're not better, we're going to move right along to the next therapy.
If there isn't 100% consensus in terms of doing the SCD, then it's less likely to be successful. This is truly a lifestyle change. And what that means is a lot more energy and commitment to your own health care. The most important thing, whether you are on the SCD or not, is that you as a patient are doing well. Making sure you properly discuss the benefits and risks of any therapy is key. These decisions need to be a team effort. Your gastroenterologist is an important part of that team. We cannot reliably predict who will improve on this diet and who won't. Therefore, proper follow-up is crucial in ensuring that you do well. With that being said, the diet works for many and can be truly transformative.